Hey, um, good evening, good morning, wherever you are, and welcome to the third day of the International Congress on Pediatrics, held by Tehran University of Medical Sciences. My name is Mariam Bakhtiari. I'm a recently graduated pediatrician, also from Tehran University of Medical Sciences, and I have the honor to be here with you guys and to host this meeting. So I'm really excited for today's session. We're going to have two consecutive sessions on clinical Down syndrome and on our experiences with Down syndrome patients. And I'm sure that this is going to be an amazing session and an awesome talk. So before continuing to our session, I just wanted to make sure and point out a few points and notes. So please make sure to mute your microphones and do not open your videos during lecturers speak to not disturb the lecturers. And you can use the chat section to write down your questions, insights, or knowledges, or any comments that you have, and we will share them with our lecturers after each lecture is over, or maybe at the end of the session. We will see how we'll go. This meeting and this session is being broadcasted live on our YouTube channel, and it can be accessed via there after this session is over as well. And for our Iranian audience who are joining us, if you want to receive CME credit for this session, you have to participate in the exam that is provided in the website after this session is over. For all of our audiences, if you want to receive certificate of attendance for this session, you should register on our website, and then you should reserve a seat on the sessions that you want to receive a certificate of attendance for them. Uh, with this introduction, I want to start this meeting. This session is going to be about clinical Down syndrome, and it is a collaboration with Arab Neonatal Care Group, with a special thanks from Dr. Ahmed Adel Hassan for arranging and inviting all of the amazing guests and lecturers that we're going to have today. So first of all, we're going to see the video clip, and then I will continue with my small talk. Okay. Sorry, I think that the video did not share properly. I will share it again. Okay, I'm sorry for the inconvenience while playing this clip. Sorry, and I hope you enjoyed this clip. So first of all, I have to thank our dear guests for joining us, and I hope you will enjoy this session. I have to thank dear Dr. Ahmad for arranging this session, for inviting all of these distinguished lecturers, and I'm sure that this is going to be amazing. And I have to thank our facilitators for this session, dear Dr. Aghai, and also dear Dr. Asu Saleh from Soleimani University in Iraq, who have accepted graciously our invitation and has joined us. And we're more than excited to hear you during our session. So I want to start our session with a brief introduction and a small talk, a small conversation to set the mood going actually. So I want to have a short history talk and a brief introduction. So for centuries, people with Down syndrome have been eluded in art, literature, and science. It wasn't until the late 19th century actually that the John Langdon Down, an English physician, published an accurate description of a person with Down syndrome for the first time. It was this scholarly article and this work, published in 1866, that earned Mr. Down the recognition as the father of the Down syndrome. Although other people had previously recognized and described some features of these patients, but this was the actual paper that started this talk and started and recognized this clinical syndrome. And after that, in recent history, actually, advances in medicine and science have enabled researchers to investigate the characteristics of people with Down syndrome. For example, in 1955 was actually the first time that they understood that Down syndrome was due to a chromosomal condition. And after that, in year 2000 was the first time actually that a group of scientists were successfully identified and cataloged each of the approximately 329 genes on chromosome 21. And this accomplishment opened the door to great advances in Down syndrome research. We, as pediatricians, envision a world in which all people with Down syndrome have the opportunity to enhance their quality of life, realize their life aspirations, and become valued members of a welcoming community. I cannot stress enough, a welcoming community, and that is up to us. I want to quote Nancy Gianni. Actually, she's going to be one of our lecturers in the next session that we're going to have. She's the Chief Belief Officer of Gigi's Playhouse and a CNN Hero Awardee. She says that all of us are one step away from being different or loving someone who is different. It could happen with a simple fall of a bike, the birth of a new baby or grandbaby, or a debilitating accident. Differences do not discriminate. They don't care who you are. When you experience that difference in yourself or someone who you love, things change drastically and you'll find yourself yearning for a more accepting world. But why wait until then? Let's start now. That is why we have arranged this session to celebrate them, to talk about them, to listen and to learn about these beautiful souls from every aspect that a pediatrician should know. We will listen to talks about the clinical aspects of the Down syndrome, and we will also listen to supportive communities and rehabilitation specialists. Sorry. So with this introduction, first of all, I'm going to start our talk and our lecture with dear Dr. Madiha. Dear Dr. Madiha Fathi, if you can hear me, we are more than honored to have you and listen to your talk. So if you could raise your hand in the audience part so that I could give you access. Um, let me. Okay. So I think that Dr. Fathi is not with us right now. So we will start with our next lecturer, and then we will hopefully have her with us in a short amount of time. So the first speaker that we're going to have, Dr. Iman Omar, specializing in general pediatrics and neonatology. Dr. Iman graduated from the Ain Shams University, Egypt, and then completed a master's degree in pediatric medicine from Ain Shams University. She then completed her training in general pediatrics and neonatology at Al Demirdash University. I hope I'm pronouncing this right. She began practicing as a pediatric specialist in 2005. She was appointed as a specialist in pediatric and neonatology medicine at the Nile Badrawi Hospital in Egypt. And in 2006, she was appointed as a pediatric registrar in one of the leading hospitals in Kuwait, Farwania Hospital, and worked there until 2014. We are more than honored to listen to her lecture about the Down syndrome emergency presentations. Sadly, she couldn't join us right now because of the conflict of a schedule, so I'm going to play her pre-recorded lecture that we arranged last week.
Good morning. I'm Dr. Iman. I'm a pediatric specialist in Jalila Children's Hospital. I'm working in the emergency department. Actually, I'm very happy to be part of this scientific gathering talking about Down syndromes. We'll talk today about the emergencies we face in the emergency department in Down syndrome patients. Okay, just 1 minute. Okay, we can start now. Down syndrome. Down syndrome, this is the most common chromosomal abnormality among inborn infants, and this is the most frequent form of intellectual disability caused by microscopically demonstrable chromosomal aberrations. And Down syndrome is characterized by a variety of dysmorphic features, congenital malformations, and other health problems and medical conditions. Not all of them are present in each affected individual. The impact of Down syndrome for each person is individual, with some individuals being profoundly impacted, while others are healthy and able to live independently as an adult. In general, individuals with Down syndrome are now reaching fuller potential, secondary to better educational programs, medical achievements, advancements, and community resources, and the support of the family and friends. Most of the common complications they face is the respiratory complication. So respiratory problems are among the most common reasons for the hospital admissions and mortality in children and adults with Down syndrome. Hypotonia, developmental delay, obstructive sleep apnea, craniofacial anomalies, immune deficiency, cardiac problems, as well as the gastroesophageal reflux all contribute to the increased risk of developing respiratory complications, such as lung infection, aspirations, and copulmonary. Also, gastrointestinal complication, the esophageal reflux is commonly seen in children with Down syndrome and can be severe enough to result in aspiration of the stomach content, causing respiratory symptoms such as persistent cough, wheezing, and pneumonia. Infants with oral motor difficulties may present with choking and gagging on feeding, as well as the respiratory symptoms mentioned. Dysphagia may affect children as well as adults, and celiac disease is the more common in patients with Down syndrome than those without it. Also, constipation is there, and it's frequently seen. Also, they experience obesity. Obesity is common, and patient needs to have a specific dietary guidelines on caloric needs and portion sizes. An active lifestyle with routine exercise is recommended for whole family, and children should be encouraged to participate in recreational activities such as swimming, dancing, walking, and playing outdoors. Also, growth is affected, and patients with Down syndrome should be monitored for disturbance of growth associated with other disorders such as hyperthyroidism or celiac disease, and for excessive weight gain. Obesity prevention. The goal of growth monitoring is the prevention of obesity. Interventions beginning at 24th months of age should include attention to diet and promotion of the physical activity. Caloric intake should be less than the age-specific recommendations for unaffected individuals. Calcium, vitamin D intake should be monitored closely to minimize bone loss, since adults with Down syndrome have lower bone mineral density than controls. Also, the cardiac complication, this is one of the commonest complications they face. All newborns with Down syndrome should be evaluated for the congenital heart disease in consultation with a pediatric cardiologist. An echocardiogram is recommended to detect abnormalities that may not be symptomatic or apparent on physical examination. Continued clinical cardiac evaluation is needed because of the high risk of the mitral valve prolapse and aortic regurg in adolescent and young adults. In a large retrospective cohort study of congenital heart surgery, patients with Down syndrome had similar mortality but higher morbidity compared with patients without the Down syndrome. Also, the experience of ophthalmological complications, eye disorders affect a majority of patients with Down syndrome. Refractive errors such as myopia, hyperopia, and astigmatism occur in 35 to 75% of individuals and can be corrected with glasses. Other common eye disorders include strabismus and nystagmus. Congenital cataracts may affect 5% of newborns and can lead to blindness if left untreated. Additional serious eye disorders include glaucoma and keratoconus. Nasolacrimal duct stenosis is common and can lead to increased tear stasis and conjunctivitis, even actually recurrent conjunctivitis. Otolaryngologic complication. Hearing loss can occur in 40 to 75% of individuals with Down syndrome. Newborns with Down syndrome have a high incidence of congenital hearing loss, and many children experience recurrent ear infections or persistent middle ear effusion, probably caused by the midfacial hyperplasia. Early and aggressive treatment of chronic ear disease can greatly reduce hearing loss in children with Down syndrome. Sinusitis, nasopharyngitis may occur secondary to narrow nasal passages and sinuses. Obstructive sleep apnea may develop secondary to larger tonsils and to other causes of upper airway obstruction. Newborns should have a newborn hearing screen and a brainstem auditory evoked response or autoacoustic emission. Infants with Down syndrome should have repeat hearing screening at 6 months of age. Hearing should be evaluated regularly throughout childhood, typically every 6 months until 4 to 5 years of age, and then to be done yearly. And any child who fails screening should be referred to ENT for further evaluation and management. The endocrine complication also do occur. Thyroid dysfunction, particularly acquired hypothyroidism, is relatively common in Down syndrome because of the increased risk of thyroid risk. Because of the increased risk, the thyroid function test should be performed in the newborn and to be repeated at the ages of 6 and 12 months, and then to be performed annually. Hyperthyroidism can develop. In addition, also type 1 diabetes mellitus occur with higher frequency in Down syndrome. The height and the weight should be measured yearly, since the combination of deceleration of linear growth associated with the weight gain is a sensitive indicator for hypothyroidism. Hematological complications. The complete blood count and the differential should be obtained at birth to evaluate the myeloproliferative disorders and polythysemia. Infants with transient myeloproliferative disorders should be followed with a complete blood count and differential every 3 months until 3 years of age, and then every 6 months until 6 years of age. Childhood leukemia is relatively common. AML is more common in infants, whereas ALL is more common in children older than 1 year. Newborns with Down syndrome are prone to transient myeloproliferative disorders. In some cases of transient myeloproliferative disease can progress to more severe disease, such as AML, within the first 4 years of life. Regarding the immunological complication, children are more prone to recurrent respiratory and systemic infections secondary to deficiencies in some immunoglobulin levels. B cells are reduced in number and function, and reduction in the immune function has been shown to be secondary to overexpression of immune-related genes on chromosome 21. Immunoglobulin A deficiency, as well as deficiencies of immunoglobulin G subclasses, can be seen in individuals with Down syndrome. and they are more susceptible to autoimmune disease such as thyroid disease. Hypothyroidism is more often than hyperthyroidism, diabetes, and celiac disease. The orthopedic complications they face, approximately 20% of all patients with Down syndrome experience orthopedic problems. Upper cervical spine instability has the most potential for morbidity and consequently requires close monitoring. Other conditions like scoliosis, hip instability, patellar instability, and foot problems can cause disabilities if left untreated. In some of these conditions, early diagnosis can prevent severe disability. Atlantoaxial instability, defined as increased mobility of the cervical spine at the level of the first and the second vertebrae, and can lead to subluxation of the cervical spine. Approximately 10 to 30% of individuals with Down syndrome have this condition. Most are asymptomatic, however, 10% of individuals with atlantoaxial instability have symptoms, including neck pain, torticollis, changing gait, change in bowel or bladder control, or other signs of paralysis or weakness. Joint dislocations due to ligamentous laxity and hypotonia are observed, and other orthopedic conditions include genovalgus, overpronation of the ankle, and flat feet. There is an increased risk of juvenile idiopathic arthritis in Down syndrome, and this syndrome is also associated with greater risk of osteoporosis, and the incidence of fracture is high, especially in patients over age of 50 years. Also, they do experience some psychological, psychiatric, and behavioral complications. The psychiatric disorders are reported in 13 to 70% of children with Down syndrome. And these conditions include common psychiatric disorders such as depression and anxiety, obsessive compulsive disorders, schizophrenia, and anorexia nervosa. Other disruptive behavioral disorders such as attention deficit, hyperactivity disorders, oppositional defiant disorders, and conduct disorders can also be present. Children with Down syndrome have autism more often than expected, and in one Down syndrome study, the incidence of autism was 7%. Current evidence indicates that autism affects just 1 of every 150 children as a comparison. While behavioral and psychiatric difficulties in persons with Down syndrome tends to improve with age, the depressive symptoms as well as problems in the social relating behavior can persist into adulthood. And it was found that persistence of depressive symptoms in persons with Down syndrome may increase their chance of developing depressive illness in adulthood. Also, one of the most important things to be taking care of is the child abuse. Individuals with Down syndrome, they are at high risk for physical and sexual abuse. Physicians taking care of Down syndrome patients should be alert to the risk to this risk, and parents and patients should be appropriately educated about this. Thank you. Thank you. Finally, I would want to talk about actually in the emergency department, most of the complication that we see is the respiratory and the cardiac complication. Maybe diabetic ketoacidosis in diabetic, well already known diabetic patients or newly diagnosed cases. So this is the most common cases we see in emergencies, but other complication may develop silent and may not be present and can be present, maybe to be clear, or can be present with vague symptoms, especially these children are sometimes not talking, not expressing. So for example, like constipation may be beginning of hypothyroidism, polyuria, polydipsia as the beginning of early start of diabetes mellitus. GERD, recurrent chest infection, so it's maybe like gastroesophageal reflux disease. So we should be taking care of them more and trying to pick these minor symptoms, not to be miss anything. And referring these children to the subspecialty and starting treatment in the appropriate time, it is the best thing to be offered for them to get the best medical care and in the appropriate time and to prevent developing the complication. Thanks a lot for your time, and I'm happy to be in this gathering and scientific gathering, and thanks a lot. Thank you very much.
Okay, I would love to thank Dr. Iman Omar for her amazing lecture on emergencies in pediatric Down syndrome patients. And sadly, we couldn't have her with us today online, but it was interesting and it was really amazing to listen to her talk. Okay, I would love to thank again dear Dr. Asu for joining us. Dr. Asu, we're really excited to have you with us today again as well. If you can hear us. Hi.
Hi.
Hi. It's really
Hi, how are you? Thank you. Appreciate.
Thank you very much for.
Hi, Dr. Hassan.
Thank you very much. Hi to you.
Hi, Maria.
Thank you very much to give your time today. And Dr. Asu, I want to ask you if it is possible for you to share some of your experiences with the fetal Down syndrome and the cultural related problems that you are facing in Iraq, and we can share our experiences until Dr. Ahmed will be joined us. Dr. Ahmed has a patient with an emergency in cath lab, so he will be with us in I think at the end of the session. And there are some topics that we can also find in the next session of today about Down syndrome, and those are about the aging process of the Down syndromes. And I'm looking forward to hear the experiences with the patients, adult Down syndromes. You know, it is a unique experience, and I myself have very limited experience with the adult Down syndrome. So I want to ask you if you can stay with us until the end of the session, and we can join for the panel discussion. Thank you.
Sure. Thank you. I will be.
Okay, so let's start our next talk. Okay, so I want to ask dear Dr. Maysa Saleh for her amazing lecture. So I think we have her with us as well, but we have a pre-recorded lecture, so I'm going to play that, but she's with us. So if you have any questions, you can write in the chat section and we will share with her. Just let me do an introduction for our dear Maysa. So Dr. Maysa Saleh is a pediatric consultant and pediatric endocrine department, Al-Jalila Children's Specialty Hospital in Emirates. She's adjunct assistant professor at Sharjah University and adjunct assistant professor at Mohammed bin Rashid University as well. Dr. Saleh is co-director at Arab Board Pediatric Residency Program, and she is an international board certified lactation consultant as well. And she will have her lecture on Down syndrome endocrinologic aspects as well. So we thank her for joining us, and we thank her for the amazing lectures. And I will play the pre-recorded lecture in a few moments.
Hi, everybody. I am Dr. Maysa Saleh. I'm consultant pediatric. I would like to express my thankfulness for the nice invitation to join this great event, the 33rd International Pediatric Congress. And actually, I have been following the last couple of days, and I am so much impressed by the highly scientific content of this conference, and I'd like to thank the organizing and the scientific committee for their efforts. My topic today is about Down syndrome, and my part of interest and passion is the endocrine. So I will be discussing the endocrine disorders in Down syndrome. Okay. My objective is to discuss the different endocrine disorders, and mainly I will be highlighting the most common endocrine disorder in Down syndrome, which is the thyroid dysfunction. I will mention the recommendation and the screening consensus, as well as other endocrine disorders. As we all know that endocrine syndrome is the most common chromosomal conditions, which is affecting worldwide about 1 every 700. And in the last survey, which was done in UAE, it happened that it is more like that, almost about 1 in 300 in Dubai. So this is a real condition that we have to follow, and we have to be prompt about their prognosis and their lifestyle as well. We all know that Down syndrome is associated with intellectual disability, in addition to other medical conditions in the form of congenital heart diseases, obstructive sleep apnea, autoimmune diseases, celiac diseases, and in addition to some endocrinopathies. This is very important because endocrine problems have more chances or more prevalence to occur in Down syndrome than in general population. So we have to be aware about the different endocrine problems to prompt to manage these problems. What endocrine disorders that we can expect in Down syndrome? So when we are doing the screening of these children, we have to put in mind, especially in the general pediatric doctors and physicians, to be aware about the different endocrinopathies like the thyroid dysfunction, short stature, obesity, diabetes, and puberty with fertility. What about the thyroid dysfunction? Maybe thyroid dysfunction, it is more prevalent in general population. So what about in Down syndrome? It is well established that patients with Down syndrome is at higher risk of developing thyroid dysfunction or thyroid hormone abnormalities. In several studies, it was estimated that it is almost about 4 to 8% of the children with Down syndrome to have thyroid dysfunction. So it is very important to pick this patient because there is really an overlap between the manifestation of the Down syndrome itself with the manifestation of the thyroid dysfunction. So it is very difficult to pick this patient clinically for this overlap. So we have to put in mind when to investigate these children and it should be in the list of the screening of these Down syndrome children for easily and early management. So we have to, as we all know, that the thyroid dysfunction can affect the intellectual power and the brain development. So we want to preserve some of the intellectual power of the Down syndrome. Thyroid screening is very important, and usually it is done annually. But let us highlight more and more about this statement. What thyroid dysfunction we can expect in this population? Congenital hypothyroidism, subclinical hypothyroidism, acquired hypothyroidism, and the most common, which is the autoimmune Hashimoto disease, and as well as hyperthyroidism. Congenital hypothyroidism, it is easy to be picked these days because of the widespread of the neonatal screening, which is almost done in every country in the worldwide. But we wanted to highlight something, that the congenital hypothyroidism is estimated to be almost 30 times higher than the general population. So we have to be very prompt when we are dealing with this patient. Congenital hypothyroidism, which is usually done in the neonatal period, there is usually a cutoff and a clear value. Whenever it is above 40, so we can suspect or prompt treat these children. But there is usually a gray area of investigation, and it's debatable area, the range between the TSH, which is higher than the normal range, which is 6 to 40 in the neonatal screening, when to treat and how to continue our evaluation and the screening for these children. Over the congenital hypothyroidism, it is referred to elevated TSH, which is usually above 10 MIU per liter, in addition to low T4. Usually we are combining T3, TSH and T4, and no need to screen for the T3. Whenever we have this combination, we have to highlight that these children needs management promptly. The second type of the hypothyroidism is the subclinical hypothyroidism, and this is very common in these children, and it is usually picked up when we are doing the annual screening of these children. This area is also of debatable area. Why? Because the subclinical hypothyroidism, which is called the compensated hypothyroidism, there is no clinical manifestation, or there is a minimal clinical manifestation, and the level of T4 is normal, but there is elevation of TSH, which is usually between 5 and 10. Actually, whenever it is above 10, it is more clear and no doubt about starting the management. But when it is between 6 and 10, and there is no, or 5 and 10, and there is no clear symptoms of hypothyroidism, it is a compensated, so we have to regularly and annually recheck it, or we have to be more often doing the investigation for the thyroid function. Actually, there is a lot of theories about the subclinical hypothyroidism. I will mention one of them, which could be due to delay in the maturation of the hypothalamic pituitary thyroid axis, and probably due to which probably it is a transitory, and it is a self-limiting process which might not require any management. The problem that thyroid, the Down syndrome, are more prone for autoimmune disorders, and the most common one is the Hashimoto. This area of investigation, and we have to do several investigation, and whenever we have suspicion of subclinical hypothyroidism, let me tell you what we are doing in our practice. Usually we are dealing with a child of Down syndrome, and I will come to how to screen these children. And we are doing our annual investigation, including the thyroid function, TSH and T4, and we are in the decompensated subclinical hypothyroidism. It is better to do the antibody with it, so we will be expecting how often or how fast will be these children going to over the hypothyroidism. The most common is subclinical, followed by the overt. Rarely euthyroid can happen. The question which is frequently asked, when to treat and how to treat. There is an incident about less than 50% that this subclinical can go to can progress to over the hypothyroidism. So the treatment of subclinical is only advised if there is conversion to the over the hypothyroidism. It is a clear picture, which TSH is higher than 10 and the T4 is low, or if there is a goiter and or there is some clinical manifestation which is more pronounced. It's difficult. I know that this area is very difficult because of the overlapping of symptoms between thyroid function or thyroid dysfunction and the Down syndrome himself and his manifestation. Hyperthyroidism usually occurs in less than 1%, but this is very important that these children should be treated. Usually it is diagnosed if we have low TSH with high T4. Sometimes Hashimoto itself can convert to Graves' disease, and it is very important to manage these children to avoid the thyroid storm and the hyperthyroidism crisis. There is several recommendations. Maybe I highlighted some adopted from the Down syndrome making group and the American Academy of Pediatrics. It is clear that we have to do screening at birth, and then we have to do at the age of 4 to 6 months, again at 12 months and annually thereafter. If at any point we are suspecting thyroid dysfunction, like increased manifestation, or it is overt that the compensation subclinical hypothyroidism, now it is a decompensated one, to go for more screening and doing the thyroid antibodies and start management, or expert consultation will be very important in this area to assist us. The timing of repeat blood test following an initial abnormal finding in TSH and T4 should be made according to the clinical judgment regarding urgency, bearing in mind that some instances an abnormal finding may be transient. That's why it is very important to check and repeat the test. What is our practice? Whenever we have like a referral to our endoclinic with a disordered or dysfunction in the thyroid test, we are repeating the test and adding to it some of the antibodies, mainly the TPO, and to see if there is a persistent elevation of the TSH and the T4 is coming down with the manifestation, we started the management. There is some scenarios which is written, and let us discuss some of it. What if the TSH concentration is above the normal range? As I mentioned, we have to follow and repeat the TSH and T4 in addition to autoantibodies, and it is preferable within 5 working days. If the TSH is above 10 with low T4, this is an overt hypothyroidism, especially if the antibodies is positive. So expert consultation or starting the management with levothyroxine is very important. If the TSH is normal and T4 is normal, but there is an elevation or abnormality or positive TPO antibodies, so we have to do the screening or the investigation more oftenly. Repeat this according to the age of the child. If this child is above the age of 6 years, we can repeat it within 6 months. If this child is less than 3 years, we repeat it from 1 to 3 months to pick up the overt or the change in the TSH and T4 and the manifestation of the hypothyroidism, so we can start immediately the management. If the TSH is below the normal range with high T4 and clinical symptoms of hyperthyroidism, we will repeat and add to the TPO the TSH receptor antibody, which is usually positive in hyperthyroidism, and start the management with anti-hyperthyroidism like L-carfenazole. If there is goiter, we will do the TSH T4, and usually we ask for the ultrasound scanning, so we can easily pick up any goiter, and if there is any nodular thyroid nodules that we need follow up and at prompt management. Sometimes, if not responding to the management, we are doing some surgery. This is for the thyroid function, which is the most common in Down syndrome, is the most common endocrinopathies in Down syndrome. Usually Down syndrome by itself is short, but adding to the complicating or the associating other symptoms of the Down syndrome, it can aggravate the growth of these children and causing growth failure and short stature as well. Some of these complicating disorders, the autoimmune ones like the celiac disease and the hypothyroidism, all in addition to some of these children having growth hormone deficiency, will add to the short stature of these children. Usually, some of the studies which was done showing that boys in the same age with Down syndrome, and it have followed by 18 years, so showing a deviation of minus 1.5 to 2.5 folds of the standard deviation. It is very important to pinpoint that there is a special growth chart for Down syndrome patient that we have to take it in consideration, and not to plot these readings, the height and the weight of the Down syndrome on the general population growth chart. No, we have to use this growth chart for Down syndrome for accurate measurement of their growth, and this is can be downloaded from any of the growthcharts.com. The Down syndrome are prone for obesity because mainly for the reduced metabolic rate, so they have a higher rate of obesity than general population. These days we have like globally a problem with the obesity, and the obesity is the hidden life-threatening problem nowadays for the children, and growing up to be an obese adult with all the complications of obesity, from type 2 diabetes, from metabolic syndrome, from problems and coronary hearts, from hypertension, hyperlipidemia, problems in the bones. All these complications of obesity nowadays, we can see it in general pediatric populations and more aggravated in Down syndrome. And usually the increase in obesity in Down syndrome become more manifested by the age of 2 years. The obesity by itself will aggravate some of the problems which is already present in Down syndrome, mainly the obstructive sleep apnea, and this is a very important complication of obesity, in addition to the liability of these children to have the obstructive sleep apnea. Also, it will be averting the diabetes, especially type 2 diabetes, which nowadays we are seeing metabolic syndrome and insulin resistance, and also the acanthosis nigricans, and all the skin manifestation of the diabetes can be seen easily in these children. And if it is left without a prompt prevention program, it will be more pronounced. So we have to inform the patient and the parents, actually the parents, about the problems of obesity in this population, especially the Down syndrome, and to put a very clear obesity prevention program for these patients. Children with Down syndrome are more liable for autoimmune diseases, as we mentioned, mainly type 1 diabetes, in addition to the thyroid and the celiac disease. Type 1 diabetes is up to 2% or 20-fold increase in Down syndrome, because they are liable by themselves to autoimmune diseases. Actually, there is a lot of patients, and in the last survey which we did in our study in our hospital about type 1 diabetes and the association with thyroid and celiac disease in general population, we found a very pronounced prevalence of other autoimmune disease in type 1 diabetes. What about in Down syndrome, which they are more liable for more than one autoimmune disease? Type 2 diabetes is also very pronounced in children with Down syndrome, especially due to obesity, and it is more pronounced in females. In general, puberty and fertility in Down syndrome in girls is not really affected. They are going to the general puberty by their age and with all the manifestation, but usually they are lacking the growth spurt which other general children will have at the age of puberty. Actually, their menstrual cycle are very regular and they are fertile. And the most common question which we are asked, especially in marital stages, about the percentage of having other child with the Down syndrome, it is usually according to the non-disjunction or not chromosomal susceptibility of this Down syndrome, but it is usually about 50%. These children or these girls is usually going to early menopausal manifestation. In boys, it's a little bit different. Puberty also is, he will go in general puberty with mild delay, but without also the growth spurt, which is usually seen in other children. There is the cryptorchidism, there is small testes, oligospermia, but they are usually having lower infertility or being infertile. The problem that these children is usually prone to osteoporosis, and we have to be sure about this and to do our investigation not to miss the osteoporosis in these children, especially in the pubertal stage. This is my ending slide, and I want just to highlight some points which is already discussed, that children with Down syndrome are likely to have developed endocrine disorders more prevalent than other general population. Endocrine disorders such as thyroid dysfunction, diabetes, short stature, infertility, as well as the globally critical problem, which is the obesity, is more common in these children. Hypothyroidism is the commonest endocrine disorder, and up till now, there is no clear or uniformly worldwide consensus about the management of these children. And actually, every hospital and every area is doing their own consensus. Thank you. This is my references. And we are in less than 1 month, we are celebrating the World Down Syndrome Day. Thank you again, and see you. And I'm willing for answering any question.
Thank you, Dr. Saleh, for this amazing lecture. We learned about Down syndrome patients with endocrinologic problems, and thank you for joining us. So if you can hear me, are you here with us? Because I could have seen you in our participants.
Yes, I am with you. Hi, Mariam. How are you? And thank you, really. I'm so sorry. I'm also at the hospital right now, and I have like some critical patients, but now I am ready to answer any of your questions. Thank you for helping me in presenting this, and thank you also the organizing, the scientific, everything was amazing, really. And I'd like to thank Dr. Ahmed Adel because he told you about us to join you in this amazing scientific thing. Thank you a lot.
Thank you for joining us, although I know that you have a busy schedule and also with having a critical patient. So thank you for joining us again today. So Dr. Aghai, if
thanks a lot. I should thank you on behalf of our team here, and we do really enjoy your very educative presentation. If I may, I want to open some discussion with you about the process of medication, starting medication, and giving therapies for the hypothyroidism of the patients with Down syndrome. As you may know, I myself, as a pediatric cardiologist, face a real problem with the Down syndrome patients, and that is the precardial effusion of these patients. As my experience says, most of these patients have precardial effusions in an amount of moderate or even severe amount of fluid around their heart. And most of the time we have in mind that the hypothyroidism of these patients is the cause of the precardial effusion. Do you agree with me that the main cause of that is hypothyroidism, and most of these patients are having levothyroxine as their medication, but the precardial effusion of these syndromes does not resolve? Do you have a cure, or do you have a solution for this problem?
Problem that usually when we have a patient from the scratch having the hypothyroidism, we are starting the levothyroxine, and we don't have any other medication apart from levothyroxine. Actually, usually we are starting even with a little bit high dose when we have the congenital hypothyroidism, even without waiting for the result of the other investigation or doing the scintigraphy. As you know, we are doing scintigraphy to know, is this children having like a agenesis or this homogenesis. We usually start with the dose of 10 to 15 microgram per kg. This is in the neonatal period. Sometimes when these children is attending later as an autoimmune disorder, as all of you know that she is more liable to that, we are starting with a higher dose of levothyroxine, and then we monitor and adjust it accordingly every 4 weeks almost. For the time being, we don't have other than this levothyroxine to help our patient, but there is some which is not really available everywhere, the IV thyroxine, which we use for some of our patients, especially those that they are not able to have their oral medication. And this medication is not widely spread, but we sometimes have to use it, especially in these patients who might not be able to take the oral and like the TPN ones and so on.
Thanks for your prompt response. Just another question: How many cases you are working in Emirates? Am I correct?
Yes.
Okay. How many cases of Down syndrome do you have in your clinic as endocrinologist consultant?
See, I cannot really know because there is no statistically done study for this, but we are in the process of doing endocrinopathies, one study, endocrinopathy in Down syndrome. I'm not sure about the exact number, but there is a quite good number. There was in 2007 a survey done about on 63,000 patients in Dubai, and they wanted to know how much, since then there is no other, how many the prevalence of Down syndrome in this area. It seems that it is something in between 1 in 450, 1 in 600. With 1 in 300 plus in the national ones, and 160 ones in 1 in 600 in the non-nationals. After 2007, I cannot recall that there is any other survey done. Maybe in the future will be, and I'll answer your question maybe next year, inshallah.
There's something. This question leads me to another question, and that's: do you have any experience with the teenage Down syndrome patients? You know, the fertility of these patients cause so many problems for the parents and for the society, as I can see with our patients here. Do you have any experience with these problems in teenage Down syndromes?
Yes, actually, we are seeing patients up to the age of 18. And according to the intellectual power of the Down syndrome and the mother and the hygienic issues, especially in girls, about the fertility and going to the menstruation. And some of the mothers are asking us, especially in some of these children, which like intellectual power is so severe, that to stop the going to the puberty and going to, but for how long? Actually, we are not able to stop the puberty for long. So we have a longer discussion and chat about this with the parents, and we will trying our best, and not only for the Down syndrome, for other handicapped or with some disability children about this area. This area is very sensitive, and some of the parents even asking us for doing giving the consent of doing hysterectomy, which is not really our practice in our area.
Okay, and this is because of the cultural problems or legal problems or something else.
Could be the culture area. Culture. I'm not sure, and we are facing these patients. We are trying to help them as much as we can, but I'm not sure about the real process, because we are not the one giving the consent of doing more further evaluation, because usually it is the part for our girls, a part of the gynecologist. Maybe they will be more good for answering this question.
Thank you very much. And Dr. Asu, do you have experiences with these topics that I just opened?
I have. Thank you for your nice presentation. Thank you. I'm Dr. Asu from Suleimania, Iraq.
Welcome, Dr. Asu. How are you?
you know, our meeting is in multinational, so it's very nice that TMS gave this opportunity to meet all of here. Okay, really, there are a lot of issues related to Down syndrome. I'm also a pediatric cardiologist, but really we are facing so many Down patients here. I did study on 600 Down patients, like 6-7 years back. Really, we found so many different things in Down patients here. I agree with Dr. Hassan about the pericardial effusion. Really, I have like 5-6 patients, the pericardial effusion not responding to any medication I am giving, even though I am giving a lot dose of diuretics. It decreased down for a while, then backs again to it. And I don't know why. And really, we are taking care about the, I'm sending those patients for endocrinologists to take care about them if they got hypothyroidic presentation. But I'm concerned about so many things. Maybe I ask you about, about the sexual life of those patients. And, especially when that's probably Dr. Hassan got the same problem, or EU also. We have patients with Down syndrome with pulmonary hypertension because they were neglected, or somewhat they got no chance for surgery, so they got pulmonary hypertension. We are obligatory giving like Viagra, sildenafil, and others. So we have also a problem with the drugs relate to some sexual things that maybe. So in that case, I'm very concerned with those patients. So so many times I'm changing medicine to others to make this problem to be like in some way to decrease. Or in that cases, what's your experience? Do you have such a thing that cardiologists referring those patients to you for just saying, how can we manage this kind of interfering drugs with sexual life?
No, actually, I don't have this kind of patient or this experience. I rarely face this kind of patient, really, if I don't have the experience to answer this question.
Okay.
Also we do have the same problem here. As you can see, there are so many patients with Down syndrome and functionally single ventricles or functionally univentricular hearts that they are in the process of the Eisenmenger syndrome, and we have to give them something to ease the life for them, to lower the pulmonary hypertension in such a way that the quality of life of them gets better. And so the first line of most of us is sildenafil, and the problems get worse.
Hi there.
Oh, so hi, Ahmed.
Yeah, I'm very sorry for the delay. I just had got an emergency pulmonary valvuloplasty, and I'm just done with it. Very sorry for that. So
I hope the patient is okay right now.
Yeah, it went very well, alhamdulillah. So it's a 4-kilogram baby, severe PS. We started with gradient 90. Alhamdulillah, we finished with grade. Okay. And patient's doing very well, alhamdulillah.
Thanks, God.
Yeah. So I can do. I'm very sorry, but I can still present, or if you want to keep it till the end, or
no, Ahmed, they are asking a very nice question. Maybe you have the experience. If Dr. Hassan and Dr. Can you again?
I think Dr. Maysa, we can go for the presentation of Dr. Ahmed, and then some of our friends here will join us, and we shall have a very nice discussion after the presentation by Dr. Ahmed.
Sure, right. I'm opening it from my computer now.
Okay, so I want to thank again, dear Dr. Saleh, for the amazing lecture. Thank you for joining us despite your busy schedule, and it was an honor to meet you. Thanks again. So, dear Dr. Ahmed Adel Hassan, thank you for
Yeah.
joining us. I'm really happy that you could join us. I'm sorry that you had a busy schedule and something came up, and we're really glad that you could make it for today. So I wanted to give a brief introduction before your lecture can start. So Dr. Ahmad is a pediatric cardiology specialist at Heart Center of Excellence at Al-Jalila Children's Hospital. After obtaining his medical degree from Ain Shams University in Cairo in 2008, he moved to Dubai to complete his internship under the Dubai Health Authority and then joined the pediatric residency training program in Latifa Hospital in 2011. Dr. Ahmad developed a passion for pediatric cardiology after volunteering in His Highness Sheikh Mohammed bin Rashid initiative for treating children with congenital heart defects in Dubai Hospital. Dr. Ahmad is a member of Royal College of Pediatrics and Child Health in London, an association for European Pediatric and Congenital Cardiology. He's a pediatric cardiologist at Al-Jalila UAE in Dubai right now, and he is also a member of Arab Board RCPAC. I don't know that, sorry. So thank you, Dr. Ahmad, for joining us, and thank you.
That's all right. Thank you very much. I don't know,
Yeah.
can you hear me well, by the way?
Yeah, we can hear you now. So if you want, you can
Awesome.
open your video as well so we could see you,
So
but however you prefer.
It tells me you cannot start your video because the host has
Oh
stopped
my
it.
God. Let
But,
me,
so let me
so
just try.
can you
I'll try to share
open
my.
your video? Oh, let me,
I'll try to
yes.
share my screen.
No,
Yeah.
you can open your video right now, and also you can share your slides whenever you're a co-host now.
Let me just. Oh, hi.
Oh, hi.
Sorry.
Hi
Yeah.
again.
So I'm sorry
Good
that
to see you.
I'm currently presenting from the Cath Lab store, so I'm very sorry
Wow.
for that. So that's not the best. This is not the way I
Exactly.
want it to be. But
Exactly. This
I
kind of
just
stuff
got stuck
happens.
here.
Thanks for
Yeah.
joining
Thank you
us
very much.
anyway.
Yeah. Thank you very much. So, okay, here we go. Good morning, good evening, good afternoon, everyone, wherever you are. I'm sorry that I missed the first part of this exciting session. Today, I would like first of all to thank Dr. Hassan for the great friendship and the great leadership in this conference, and for inviting me and my colleagues to be here now. I'm going to have a presentation. Hopefully it is interesting. I'll try to make it quick. And it's basically a closer look at the beautiful hearts. This presentation was started, I prepared this presentation initially for the World Down Syndrome Congress, which was done in Dubai in last November. And I did some modification for the purpose of our audience. Yeah, so here we go. So this is where I work. I know that it looks like, it is part of the metaverse and NFTs, but no, this is where my hospital is from France. This is Jalila only children hospital in Dubai. And I'm working in the heart center of this hospital. This is how this is a hospital from inside, and between these three walls, the four walls of this hospital is actually all the specialties that a Down syndrome child would need to take a very good care of them. So by the end of the presentation, we will be understanding more the importance of an MDT multidisciplinary team approach for a Down syndrome. Most of the patients in our heart clinic are some of the patients in our heart clinic are Down syndrome, and we will talk more about what do we see in these patients. And of course, cuteness come in different shapes and sizes. Actually, Down syndrome kids are some of the cutest of our kids. that come to our clinic, and we are fully dedicated for their support. Just a quick, refresher about things that's important to understand what really goes wrong in Down syndrome patients that gets a congenital heart disease. So, and this is actually how we explain it to the parents. We explain to them that a heart formed of 4 chambers, and there are 2 pumping chambers that pump the blood to the body. The left one pumps the red blood to the body, and the blue one, the right heart, pumps the blood to the lung. The blue blood goes to the lungs, the red blood goes to the body. Red blood oxygen, blue blood is low oxygen. And the most important point here, actually, in my opinion, to make everyone understand that this side of the heart, the left side, is really high pressure compared to the right side of the heart, which is really low pressure. And just to give you a flavor, a pressure of this left ventricle would be sometime, I mean, in a baby or in an infant, will be somewhere between 60 to 80 or 90, while here will be probably just, in 20 or 15. So, and this is actually where all the problem starts when we talk about the problems we face in Down syndrome patients. So, an important thing to talk about is that is the presentation going well, by the way? Can you see my slides? I'm sure, yeah?
Yes, perfect. We can hear you and we can see them. Amazing.
Awesome. Awesome. Thank you very much. So the Down syndrome journey starts actually before the baby is delivered. So most of the Down syndrome can be diagnosed in fetal ultrasound and then blood samples and stuff. But the problems, the cardiac problems of Down syndrome most of them can be diagnosed fetally. So we are glad to have in our center, and actually in most of the international centers, probably all international centers, they have a fetal echocardiographer, which is most of the time one of the pediatric cardiologists interested in scanning hearts of babies and their pregnant ladies, and we get most of them. So it's very important because it makes a big difference when the parents receive their baby with knowing that he has this heart problem. What is it? Understand it, and in many places, including our place, they need some time to be financially ready. They need to do a lot of life changes to receive the new guest. So fetal echo really is important, and it diagnoses most of the problems. And the second thing is the echocardiography, which is done in the cardiology clinic. And I believe that every Down syndrome should at least visit a cardiology clinic once in their life, if they have a normal heart. If not, then probably they will be our friends and family for treatment. And the other things we use is the advanced imaging, cardiac CT, cardiac MRI. It really gives us very important information in certain cardiac problems, and this is available in most of the big centers. And of course, cardiac catheterization is one of the modalities that we sometimes need to collect information and sometimes to treat problems, closed holes, open valves. It's really a helpful thing. So So how do we approach families? So these are if we diagnose a heart problem in Down syndrome kids, we make sure that the family understand well what we look at and what we want them to watch at home. So we tell them clearly, you know, guys, if you feel your baby is breathing fast, like running a marathon or being a football match, if you feel at any point of time that they are not able to feed properly, they are not having the milk they expected to have, or if you feel that they sweat really a lot during feeding, or if they are not following the Down syndrome growth chart, basically failing to thrive and failing to gain weight, if they turn blue when crying or with effort, you have to reach out straight away. In our center, we have emergency 24/7, but in some patients, we leave even our WhatsApp number or mobile number because we really need to know as soon as possible, and then we arrange things for them. So this is what we tell them. So if unwell, you have to go to the nearest emergency. You don't have to come to our emergency in case it's far away. And then we arrange the later transfer. And if it's stable, but you know things are getting a little bit changed, you can go to your pediatrician or family physician, or you can come to the pediatric cardiologist straight away, and then we will reassess ourselves and go ahead with that. All right, and next, yes. And I will talk about a few of the hard effects that can be on Down syndrome kids. So, so the first thing that actually one of the common congenital heart problems that we see in the in Down syndrome babies are the complete AV canal or the complete AVSD, and it's not as simple as AVSD is not simply that there is atrioventricular septal defect, which is basically that we have an ASD and VSD. It's not as simple as that. The culprit is this point, which it's called the cross of the heart. If you can't see, I don't know, can you see my mouse? I assume you do. So this part here is deficient in Down syndrome kids who have a complete AV canal, and the resultant is that the lower part of the septum primum here is not formed, and up and part of the muscular part of the muscular septum of the ventricular septum is not formed as well, as you can see here, and then these two separate valves become a single valve, which we call it a pentaleaflet valve, or just single AV valve. So that's one of the first. Now, just to understand what's going on here, this side, as we said, is a high pressure, and this side is low pressure. And now the problem we get is that the blood goes from the high pressure area to the low pressure area, and then there are more blood goes to the lung. This is the pulmonary overflow is really the problem here. Another example of the problem is just isolated VSD, and the VSD can be, as you all know, it can be membranous, perimembranous, or muscular, or So basically, it is very interesting to know that this ventricular septum is like it's like the map, and this map, we keep on describing by echo where exactly on this map the VSD, because everyone have a different prognosis. Some of them close on their own, some of them can be closed on the cath lab, some of them need to be closed straight away. And again, the problem here is that the very high pressure left side, because the left side is very high pressure, and now there is a hole here. So the blood goes from the high pressure to the low pressure, and the poor lung will receive much more blood than it's designed to receive, and this is this really the problem is. So when we say that the QPQS, or the lung to pulmonary to systemic circulation, is 3:1, means that the lung receives three times the blood goes to the body. So if you assume, theoretically, that the lung receives 3 liters of blood, then the body receives 1 liter of blood, and then you can imagine that poor lung that is really at the sponge is getting hammered with loads and loads of blood. And this is another example, the ASD secundum, or which is a hole between the two atria in the interatrial septum. It's just in the middle here, and it is due to deficiency of septum secundum. And what really causes that the blood here fills again from a bit higher pressure to a lower pressure. The blood goes here during diastole, and the diastole is the time when the ventricle is relaxing. So the right ventricle really dilates here and again, much more blood goes to the lung. And tetralogy fellow is one of the entities we see in Down syndrome patients. And you can, and if you look at here in the normal part, you can see that this area here is really the problem. Yeah. So this area here, let me make sure that you can see my. Okay, I hope this can be useful. So
Yeah, it
this
works.
area here. Yeah, thank you very much. So this area here is really the problem, you know. So for some reason, yeah, and to be honest, you'd be surprised that until the moment, as much as this entity is very well known, still there is a very advanced studies on the histopathology and the fiber arrangement and genetics of this entity of problems. Now, this part of the ventricular septum just moves all the way here. Can you see that here? So now this part just moved all the way here. And guess what? This gets the pulmonary area is very, to be very tight. So now the pulmonary, the blood goes to the lung are very, very little. Can you see that? Now this area is very narrow. And because of that, the valve, pulmonary valve is very narrow. And whatever after that actually becomes narrow because the growth of organs in the heart is what we call it flow dependent. So wherever the flow goes, area grows. If the flow doesn't go, it really doesn't grow. So you'll find that the pulmonary arteries might be small, and and the pulmonary valve is small. So just to make things simple here, the problem here is that the lung receives little blood. The other problem is that this area is really muscular, so it can, guess what, it can contract, and if this area contracts, it results in what is the famous cyanotic spell or hypercyanotic spell with very low saturation, and the result will be that the baby is blue. This hypercyanotic spells, by the way, can be fatal. Right. So let's talk about what the treatment options in the Down syndrome, patients. So I divide it into diet. Yeah, diet. Surprisingly, diet is very important. We really do care about the diet of cardiac patient with Down syndrome patient with cardiac problems, and there are many medications that really help in the management. Cardiac catheterization, or how we describe it to the families as a keyhole procedure, and surgery. So these are the treatment options that we have for Down syndrome patients. And really diet is, why the reason is I'm saying diet is really important for Down syndrome patients, that it is important to enhance the weight gain. Yeah, they have loads and loads of blood going to the lung, and because of that they are panting like really breathing really fast. And you cannot expect with that a baby to grow well. So we really need to enhance their weight gain. And there is a miss, unfortunately, in the pediatric world, that cardiac patients restrict fluid, just gives them 80% of the the maintenance, or you just gives them 100 ml per kg per day, which is in many of the congenital heart problems is not right. The reason is that they really have a strong muscle. Most of the congenital heart problems have a good muscle that can take a good amount of fluid. So our protocol is that we have to go up to 150, 160 kilocalories per kg per day. We make a very important team with the dietitians and the gastroenterologists, and we try to make sure that this happens, because most of our treatment options need a bigger weight. So we want babies who are 5, 6, 7, 8, 10 kilograms to do certain things, and we can't do that without a good weight gain. And we don't restrict fluid in there. The second thing is the medication. So we have the heart. So if the patient exhibits heart failure symptoms, we diurese them to the maximum. So this is how actually how it works. So yeah, we give a lot of fluid, but we give a lot of diuretics. So we make them pee like anything. And even the family say, you know what, the medicine you give me, make me change the diapers many times, but I have no problem with that as long as the kidneys are right. Of course, we follow up the kidney function, but also, and the kidney usually doesn't have any problem with that. But really, this makes them grow faster. And we give the AC inhibitors because they are peripheral vasodilators. They allow the blood to go more to the body on expense of the lung. So more blood go to the body, less to the lung, and it improves the cardiac function. And those patients who have cyanosis, tetralogy below patients, we give them because of the low saturation, we give them aspirin. So because many of them, or actually almost most of the cyanotic patients, have really high hemoglobin and a higher chance of thrombosis. So we give them aspirin, and we give them beta blocker. As we explained in that image, the muscular part is really hyperactive and can be get tight, and beta blocker really helps in relaxing this area. Third line of treatment is catheterization. Cardiac catheterization in our center, and actually in many centers around the globe, is really fundamental. We use catheters to gather important information. An important thing that I have to mention here, as long as I'm talking about Down syndrome has a higher chance for going to pulmonary hypertension faster than normal kids. Yeah, so if a patient if I have a Down syndrome with VSD and I have a normal kid with a VSD, that Down syndrome might go in pulmonary hypertension much faster. And sometimes we get a patient that present to us at 1.5 years of age or 1 year of age with have a VSD, and we need to close the VSD, and we're really worried, is he already pulmonary hypertensive or no? And for that we do catheters, we collect important information. When, you know, many of the VSDs or ASDs, or actually majority of ASDs, are closed by in the cath lab. You know, our surgeons are really, you know, it doesn't like us much because we don't leave them easy ASDs. We don't let them take any ASDs. Of course, I'm just kidding, but with certain ASDs we leave it with a bench of salt, and many of ASDs we close them in the cath lab as well. So many of the high muscular VSDs or any bare membranes VSDs, we close it in the cath lab. So this is how important cath lab is. And of course, we open tight valves or arteries. So for example, many of the Down syndromes, you know, that they need to increase the blood flow to the lung. We take them to the cath lab. We do what we call an RVOT stent. So we go in the right ventricular outflow tract, this tight area where the muscle is really tight, and we put a stent in, or we balloon this area, and we allow more blood to go to the lung. And this is by some time until, you know, they grow and reach the time to do a proper tetralogy flow repair, for example. And sometimes we do it as a life-saving, yeah. And what I described, the RVT stent, or, you know, opening up the right ventricular outflow to allow more blood to the lung, is one of the life savings. Sometimes we do it on life-saving basis. Yeah. So this is the rule of cardiac catheterization, and of course, surgery is the the ultimate treatment for many problems. Like, for example, complete ABSD, the treatment is surgical. So usually surgery can be either a full correction, so they reach 5-6 kilograms, we do the surgery, and that's it, become a history. Sometimes we do it in a stage correction, as we explained. Sometimes we need, you know, to do in some of the problems I described, where there is so much blood goes to the lung and the lung are hammered, and the baby is very small, to do a full correction. The surgeons sometimes go and they do what we call a BA band, or pulmonary artery banding, where they tighten the pulmonary artery so it reduces the blood goes to the lung. And sometimes again, the surgery can be a life-saving option. And as I described, and as I said in the first slide, the treatment, you know, these kids, Down syndrome kids who have a heart problem and many of their other health problems, need to be treated in a children's hospital, because all the titles on this, on all the specialties on this slide are actually needed. So we starting from pediatrician, pediatric cardiologists, surgeons, nurses, dietitians. When we talk about surgeon, cardiac surgeon, pediatric surgeon, physiotherapists, ICU doctors, ICU nurses, speech and language therapists, occupational therapists, all are really, we all work as a one team, and we all need each other. So Children's Hospital is this is fundamental to have a Children's Hospital for every population, and these patients need to be treated actually in Children's Hospital. So, ladies and gentlemen, I think the take-home message from my presentation here is that kids with Down syndrome, I believe that they need to get an echo at least once in a lifetime if everything is all right. I think Children's Hospital or specialized centers are really important to manage them, and multidisciplinary team approach is really the way forward to deal with these patients. And I hope that I didn't take so much of your time. This is my email if you have any questions, and thank you very much for your attention.
Ahmed, thank you very much. I know how busy you are, and I can see that you are joining us from Cath Lab. So thank you very much for your nice presentation. Let me just ask my first question, and that is, who is in charge of a patient with Down syndrome in your center? I think a patient of Down's, a management of a patient with Down syndrome is actually a multidisciplinary thing. It is not for one subspecialty to manage all the problems of a Down syndrome. So is there anyone in your center that is the main person related to a patient with Down syndrome, or no, you have not such a person in your center?
Yes, so I worked in two centers. One center, the genetist, the genetic doctor was the one who is, the following up the Down syndrome. They have a protocol. I'm not sure if Dr. Madiha was able to join. Unfortunately, she's in Sudan. Yeah, the internet in Sudan is very bad, but she had a presentation, and her presentation
Dr.
was...
Ahmed, let me clear this, because I know there is a one-day clinic mainly for the Down syndrome managed by the genetic people, and it is once a week. It's still running in our hospital, a Down syndrome clinic.
Yes, so so as Dr. Maysa said, she's the expert in that we have a specialized Down syndrome clinic, and I know some places they have what is they call a complex care clinic, where they treat these patients that need multidisciplinary. So they make sure that they see the pulmonologist, cardiologist, GIT all in the same day, for example.
So who is the person that leads this clinic? Genetician or a pediatrician, or I'm not sure. A general
actually, in our hospital, it is the genetics, and from there they can refer to whoever. And wherever Dr. Madiha is working, which is actually in Qassimi Hospital, Sharjah, it is run by herself, a Down syndrome clinic, as a general pediatrician. And she was our colleague previously in Latifa Hospital, which she also used to run this clinic.
And some question that is I want to ask you and also Dr. Asu. Have you experienced with the Down syndromes with single ventricle morphology? What do you do for these kind of patients?
If Dr. Asu allow me to, I'll say my part first. So with Down syndrome patient with single ventricle, we probably, or actually we treat them as any other kid. So we don't deal with them as disadvantaged or hopeless. So we deal with them as any other kid. We had many patients who have unbalanced AVSD. We do struggle. They are one of the most difficult, to be honest. If you tell me now what is some of your nightmares during your practice, I'll tell you the Down syndromes who have an unbalanced AVSD or complete AVSD is that we struggle a lot with let them gain weight to go for the stage approach, or to go, for example, for a Glen, or to go for a, a full repair. So we struggle with them, but they get equal opportunity. You are muted, Dr. Hassan.
So, Dr. Asu, what is your experience with the Down syndrome with functional univentricular heart? Do you go for the next steps, or you just said that the prognosis of the single ventricles with Down is not so good for having them surgeries for single ventricle approach?
Dr. Hassan, thank you. There are a lot debates around Down syndrome patients, because the pulmonary vascular resistance will change sometimes with age. So, and the pulmonary vascular base is different from the normal people. So maybe single ventricular repair is not a good option for them, although some doing it. And also, Down patients, they got other problems related to the Down syndrome itself. So they will get endocrinal diseases, and their immune is not good, and as well as they may get other diseases. So eventually, the prognosis related to single ventricular repair will be very bad. I think it's not a good idea to go farther for the repairs. This is one. Second, when you are doing surgeries for those patients, they are at high risk, because even the anesthesiologists struggle with their anesthesia even. So that's I agree with Dr. Ahmed that this is a nightmare for the cardiologist, even for doing cath for those patients. I have an impression that when you have Down patients with delayed diagnosis for congenital, their pulmonary vascular resistance so high, so it's better not to touch anything, because you will do bad for the patient. And the aim of the goal is to let them to live safe but not die on the table.
I agree with Dr. Asu regarding the definitely there are some patients who just miss the boat, and you cannot do good for everyone. As Dr. Asu rightly said, they go on pulmonary hypertension really fast, and there's some patients with them, as with non-Down syndrome patients, if they are, for example, Eisenmenger, or the pulmonary pressure is not allowing for a repair, we wouldn't, of course, do it. We wouldn't do it in normal. We wouldn't do it in Down syndrome. But still, we give Down syndrome that chance if they are, suitable for the chance.
So, if I may, there's a question left before the presentation of Dr. Ahmed, and that was the prevalence and management of celiac disease in the patients of Down syndrome. And one of my colleagues, Dr. Rohani, just accept our immediate invitation and just joined us. Dr. Rohani, are you with us?
Hello.
Hello,
everyone. Hello, Dr. My dear friend. Yes, I'm with you.
Thank you very much. Thank you very much for accepting the invitation in short notice. Do you have experience with the celiac disease and Down syndrome?
It's a great question, Dr. As you know better than me, the patient with Down syndrome are more than the general population predisposed to celiac disease. There are different statistics about this, but the most important reference that we have told us the children with Down syndrome are something around 6 times more predisposed to celiac disease in comparison to the other children during their lifetime. as a matter of fact. And as you know, the more GI complications we see in patients with Down syndrome, especially constipation is a very common problem in patients with Down syndrome. And maybe one of the reasons behind this constipation be a celiac disease, and we have to screen even any asymptomatic patients with Down syndrome for celiac disease, as a matter of fact. And some guidelines predispose that you have to screen the patients every year, but some of them maybe tell us if the patients have some sign and symptoms that give us a clue for diagnosis, like, for example, constipation, FTT, in comparison to the other Down syndrome patients, and or diarrhea or sometimes. And these are the patients that we have to screen the patients more immediately in comparison to the asymptomatic patients. In addition, from birth, the patients with Down syndrome are predisposed to many GI abnormalities and anomalies. As a matter of fact, one of the common of them is imperforate anus or unperforated anus. Both terms are correct, as a matter of fact, and this is very important that we have to keep attention about the proper anus location of the patient with Down syndrome. This is very important. In addition, maybe the patient with Down syndrome are predisposed to Hirschsprung disease, and it's very important that we have to keep attention about Hirschsprung in patient with Down syndrome. In addition, we have to take care about the other anomalies of the GI tract. For example, if the patients have vomiting immediately after birth, we have to search for intestinal atresia, especially duodenal atresia is very common in patients with Down syndrome. As you know, the GI experts tell us that more than 50% of the patient with duodenal atresia are Down syndrome, as a matter of fact, and it's very common in this population. Of course, overall, it's not very common, but we have to keep attention about the other anomalies and conditions that patients with Down syndrome have. And GERD is more common in comparison to the other problem. GERD is more common in patients with Down syndrome, and we have to care about it because, as you know, the feeding in this patient sometimes is more problematic, and we cannot solve the problem very easily because they have feeding disorder, they have feeding aversion. Many times, especially we introduce solid foods, and it's very important for catch-up growth in these patients. And these are the summary of one of the important GI problems that we have in patients with Down syndrome.
Okay, Pejman, there is an experience we have faced with our patients, and that is the prevalence, the high prevalence of precardial effusion in our syndromes, the collection of the fluid around the heart. And when we face a patient with Down syndrome, that the fluid around the heart, the precardial effusion, is somehow not respond to the traditional therapies that we use, we go for the celiac disease. Have you heard anything about that? The association of the pericardial effusion in Down syndrome with celiac disease?
That's a very great and important question because, as you know, Doctor, better than me, the different presentation of celiac disease these days is very common, and the last study about presentation of celiac disease in Spain during, I can say, 1 week is published now, give us the different presentation of celiac disease in patients, especially in children, and showed that the picture of the celiac disease during the last 10 years completely different from the presentations we had before. And one of the rarest, I can say, presentation maybe in patient with Down syndrome or many other patients, of course, is the odd and very rare presentation of celiac disease. And we have to care about precardial effusion in patient patient with Down syndrome, especially, and we have to work up them. It's very rare. It's very rare, as a matter of fact, but it's very. We have to check it when the patients have precardial effusion about, and the new literature insists on that. If you suspect to the, when you as a cardiologist find the precardial effusion, then we have to suspect to celiac disease in this patient. And it's a very rare presentation, but we have to consider that. In addition, celiac disease in patients with Down syndrome predispose them to recurrent intussusception. And sometimes when you have, for example, a intussusception attack and it's relieved by own, should take care about that. And we have to consider that maybe the celiac disease predisposed patient to this attack of intussusception. It means that different presentations is expected, as a matter of fact. And as you told us, it's a very important points that we have to consider.
Thank you very much, Pejman. I know this is the night of the holiday in Iran, and thanks a lot for joining us in this panel.
Thank you very much, Doctor, for invitation. And I want to say that you are one of the best colleagues we have in Tehran that, of course, not only in very special experiences in cardiology, and one of
That's
the
so kind of you. Thank you very much. Thank you very much.
For your
you too. Thank you very much.
It was fantastic.
Have a nice afternoon. There's another colleague of mine that she's a very good colleague of mine. She's a psychologist and adult psychologist, and she just joined us for a question that have been raised during the session. And Dr. Taheri, are you with us? Dr. Taheri.
Dr. Taheri, you are a co-host now, and you can open your video and also your microphone.
Yes, hello everybody.
Hi. Thanks for joining us.
My son. Thank you. Hello, my colleagues, and I'm so happy to join you.
Thank you very much to accepting joining the panel in short notice. Thank you very much, Aida. There's a question that have been asked by by our colleagues during the this session, and that is about the process of aging and what are the psychological problems that Down syndromes will be faced in the adulthood. For example, are they facing depression, and how can you manage them, the depression, anxiety, and can you guide us through the adulthood of a Down patient?
Yes, as you know, the Down syndrome patient are more emotional and more sensitive than other people. So the research suggests the risk of suicide, the risk of depression, the risk of neurotic patient between Down syndrome is more than other people. They are more predisposed to general anxiety disorder because they experience more anxiety in their life, and they couldn't learn
social capability. I think.
Yes, social capability, and they couldn't manage their stressful situation, so they predisposed to anxiety, and they know after they become mature, they know they haven't the ability of a good ability, and they think we are different, so they experience more depression. Minor depression is more
Prevalent, huh?
minor depression. Excuse me?
The incidence of minor depression is
yes, the incidence of
higher.
minor depression is more than major depression between Down syndrome, but the risk of suicide is not more than between Down syndrome and other people in the same situation. For example, if a group of people with major depression disorder without Down syndrome and a group of people with Down syndrome, when you wanted to when you wanted to research between them, they haven't they aren't more predisposed to suicide, and but because they have less IQ, so they couldn't do a suicidal attempt in a best way. I think we said attempt suicide and positive suicide, I think.
And is this
okay.
Are there any differences between the management of depression in Down syndrome and management of the normal population?
Yes, yes. As you know, we don't have the cognitive rehabilitation and cognitive treatment to Down syndrome. The Down syndrome couldn't work in cognitive situation because they haven't a good cognition. So we have to give them a behavioral therapy, just behavioral, such as children.
Thank you very much, Dr. Taheri. It was a great honor to have you tonight with us. And hearing your voice is always joyful for me. Thank you very much. I know you were busy tonight, but you accepted with so kindness. Thank you very much.
Thank you. Have a good time.
Okay, so thanks everyone. Thanks everyone for joining. I can't thank you enough, all of our lecturers, all of our guests, for this amazing conversation, for all of these topics that were brought up during this session. And I myself, as a pediatrician, has learned a lot today, and I'm really blessed and I'm really honored to be here and to listen to this conversation, to be a part of this amazing team, to share their experience, to listen to all of these amazing specialists in their field and listen to these amazing and awesome knowledge and information. So I have to thank, especially I have to thank all of our dear Dr. Ahmed, whom is walking through Cath Lab. So thank you. Thank you for joining us. Thanks for arranging this meeting. Thank you, Dr. Alsi, for joining us. Thank you. Thank you. Yeah, thank you, Dr. Alsi, for joining us. Thank you, Dr. Rohani. Thank you, Dr. Rohani, for joining us on such a short notice. Thank you, Dr. Taheri, for joining us on a short notice. And also a special thank to dear Professor Aghai, as always, as a team of our team. So I want to end this, and also, sorry, I forgot, our dear lecturers, of course, Dr. Iman Omar, Dr. Maysa, Saleh, and sadly we couldn't have Dr. Madiha Fathi, and also Dr. Ahmed again. So thanks again, everyone, for joining us. We will have our second, Dr. Ahmed, go on.
I would like to thank really Dr. Hassan, of course, the architect of this meeting, and Dr. Mariam for the really great effort. It was really brilliant, and I'm in the conference in the business for a long time, but you're doing a very good job.
Thank you very
Thank you
much,
very
Ahmed.
much. Obviously.
I am so excited about our next session, that is social problems with the Down syndrome, and we can share our views. We are living in the same region of the world, but there are different cultures. You know, we can share our experiences with other parts of the world, and I would like to invite all of you audiences to join us to the next session and enjoy what the NGOs that are doing such great things with Down syndrome have to say to us. Thank you very much, and see you in about 5 to 10 minutes. Thank you very much.
Dr. Mariam, you are muted.
I was talking for myself, so thank you for me. So thanks everyone. Yeah, we'll see you in 15 minutes, which will start our session on our experiences with Down syndrome patients and Down syndrome foundations that are gonna give their amazing lectures. So see you in 15 minutes. Bye.